Wonderful, good to see. And already we have 43 participants, although we are only 5 minutes away, which is wonderful.
Assalamualaikum.
Walaikum salam. Amir, क्या हाल हैं, कैसे हैं? ठीक है?
Alhamdulillah. I can't open my video.
If Imad, can you switch on Amir's video, please?
1 second, sir. His option is off. I don't know why.
Amir, you want to connect with another device? Do you have another laptop on you or another?
I have a laptop with me.
You're connecting from laptop, so you have to go that option near the mic, start video. Do you have?
I'm clicking it. Yes, I'm clicking that. Make sure that
लेकिन
your
बराबर
camera
में
is powered on.
लेकिन सर बराबर में इसके एक arrow है. You have to click on that arrow, then video setting.
Audio setting का यार.
Yeah, then you can select your camera.
तो सर के लिए मसला होगा नहीं, ये हेडफोन है ना, ये माइक है, माइक है ना, तो हेडफोन मिलवा दो.
अंजुम साहब, आप कैसे हैं? All good, alhamdulillah. How is Lahore behaving? How is Lahore behaving? Hello. Hello. Hasan, can you hear me?
I can hear you.
I think
उस पे इतनी अच्छी नहीं आती ऑडियो क्वालिटी.
Anjum Saab's audio is not good.
Headphone. No, he's trying to connect a headphone, I guess.
Yeah, I think that would be a better option.
Yeah, he's wearing headphone now.
Anjum Saab, can you hear me?
Yes, now I can hear you.
Good. You just need to increase the volume there. The volume may be in your...
But I think with the headphones, I can hear you better.
Yeah, but we need to hear you from your mic, which is here, next to your... Amir, apna phone to off kar dein, please. Yes, but the mic is very low. The volume in the mic, so you have a volume control over here. There's a volume control in the headphone, just on the wire over here. So you can increase that volume. Amir साहब, आपका मसला हल हुआ?
नहीं सर, वीडियो का मसला हल नहीं हुआ. मैं जिसे I want to introduce all of you. Let me introduce with audio only. Hello, Assalamualaikum. Can I start, sir?
No, we are just waiting for Anjum Saab's mic to get fixed. We can't hear you, Anjum Saab. Now, can you speak now, Anjum Saab?
Can you hear me?
No, your voice is very, very dim, very low.
So can you hear me now?
Now we can hear you better. Yes.
Okay. I'll keep this mic in front of my mouth then.
Sir, inshallah.
Okay. Can you hear me?
Yes, we can hear you well now. Everybody can hear Anjum Saab well?
Yes, so quite dim his voice, but it's okay. We can hear him.
Okay, shall we start? We have 73 participants and increasing, so we can start actually. Today's talk is by our dear friend, but I think I'm going to introduce the two moderators. Our senior neurosurgeon from Lahore, Anjum Habib Vora. He's been very kind. When I came back to Pakistan, we started with a workshop, and he was the first one to come and get involved in all the activities, hands-on. He and Raja Saab both used to do that for us, and we would remember that always. We have him as a moderator today, alhamdulillah, and we also have Amir Sagir from Karachi as moderator. I'd leave it to both the moderators to take it away from here, please.
I'd like to say something.
Can we start then?
Yes, please.
Yeah, as Professor Salman has introduced me, I'm Professor Anjum Habib. I am ex-principal and former professor of Amiruddin Medical College and Lahore General Hospital and Postgraduate Medical Institute. I had my fellowship in 1985, and since then I'm working as a neurosurgeon, and I have served my country for over 30 years, and most of the neurosurgeons working in Punjab, in Afghanistan, and nearby countries are trained by us. Today's speaker is Dr. Syed Hasan Raza. He is assistant professor in University of Virginia since 2017. He did his medical degree from Virginia Commonwealth University. He did his master's degree in cancer stem cell biology from King's College, London. He has neurological surgery residency with Dr. Kibben at Georgetown University, where he won various awards in traveling fellowship from AANS in CNS section on pediatric neurosurgery. He had specialty fellowship in pediatric neurosurgery with Todd Tomita, who is a renowned pediatric neurosurgeon. His interests are broad-based, involving all kinds of pediatric neurological problems. He also likes traveling and spending time with his family. Now I request Dr. Syed Hasan Raza to present his talk on craniosynostosis. He will let us know when it should be done and how it should be done. Dr. Syed Hasan Raza.
Thank you so much for that introduction. Really, it's an honor to meet all of you and to be here again. Obviously, the topic is a little different. It originally was vascular. I was looking forward to seeing Azam, and hopefully he will have a talk at some point in the future. But Dr. Salman also asked me to sort of discuss craniosynostosis specifically, the general techniques in surgery and when it should be done. So, I'm very excited about this talk, really for three reasons, and hopefully we can spend some time and dissect this topic a little bit and answer some questions. But the three reasons I'm most excited about craniosynostosis is, number one, it's really a pleasure to work with kids, especially with this type of pathology. We see kids that are in need of help, and we see good results from these types of surgeries. The second reason I do enjoy treating craniosynostosis is you're able to work, depending on your institution, with a whole team, a craniofacial team that includes other surgeons, other providers, and that's really a pleasure to be able to work in a team-based approach. And then finally, explaining things with, in a time of need for, especially with parents, because they can be, how should I say, very, very nervous during this whole process. It can be pretty fulfilling to be able to discuss these pathologies and put parents at ease. So with that introduction, I'll kind of go through sort of the objectives. What I'd like to do is review the history of craniosynostosis and the evolution of the theory. Then we'll go on and define what the difference between syndromic and non-syndromic craniosynostosis is. But we'll focus on management of non-syndromic craniosynostosis because the syndromic cases is probably another lecture of its own. And then we'll move on and compare each type of a pathology in terms of premature fusion of those sutures, the management techniques and the timing. And again, we'll emphasize the historical perspective on a correction as well as current literature. And then I'd like to just briefly present some results and data from where I work, from the University of Virginia, and our evolution of the history of treatment of this, specifically for sagittal synostosis. So when I was looking into, doing these talks, I always find that, learning the history is important to understand the perspectives of where, certain treatment options have been and where they are going. And so I really found this quote interesting. This was a quote from Dr. Pruzanski, who was actually an orthodontist, a dentist, but he was director of the Craniofacial Anomaly Center at the University of Illinois in Chicago. And so his quote really made an impression on me. What he really defined craniosynostosis as, or basically said that the reason it intrigued him was that it was essentially like a play or a drama of nature in which the Sturm und Drang, which is German for storm and stress. So the storm and stress of nature of a growing brain and its hydrodynamic forces compete against the rigidities and sometimes yielding barriers of a brain case derived from dermal placodes and primitive cartilage. So essentially, it's sort of a play between the pathology and what the brain wants to do or what it normally does, and the implications that this pathology has on the brain. And sort of that is why we as neurosurgeons are involved in the care of these patients, and it's important to note that. So when we think about the origins of craniosynostosis, we find that people from really ancient history have been describing elements of this. And in fact, in the Iliad, we know is the ancient Greek poem that was set during the Trojan War. Homer describes the warrior Thersites as, quote, the ugliest man who came before Troy. His head ran up to a point. And essentially he was describing what is known as oxycephaly. So certainly throughout history, this has been present. And physicians as far back as Hippocrates and Galen recognized the relationship of cranial sutures to skull deformities. And in fact, in the 16th century, Vesalius, in his pivotal publication, even had pictures and described these conditions as well. But it really wasn't until 1791 when von Sommering was the first to describe the bone growth in the skull as occurring primarily at the suture lines. And he noted that an abnormal head shape would expand in a plane parallel to a fused suture. And that's really critical because that is the underlying pathophysiology. And later on in the 1850s, Virchow, who we all know, was a famous German physician, pathologist, politician, a lot of contributions to medicine. He was the first to describe the characteristic abnormal growth patterns with specific synostoses, and he classified these morphological descriptions that we even use today. And so really the premise that the normal skull growth tends to be in a plane perpendicular to the suture, and abnormal growth that is parallel to the fused suture is named after him and known as Virchow's law. So moving forward, Dr. Lane was prompted with this question from a child's mother: can you not unlock my poor child's brain and let it grow? And again, this really emphasizes the underlying pathology and why neurosurgeons are so closely involved in this when it comes to the brain. And so he was credited to perform the first surgery of premature sutural closure in North America, at least in 1892. His compatriot Lenolog performed surgeries for this condition in 1890. He advocated release of the suture and not resection specifically of the fused suture. So again, although the first surgery was done, important to note the patient died, I think 14 hours post-operatively, reportedly from complications of anesthesia. So people began doing surgeries at that time for this condition. And really that changed when this gentleman here, Jacobi, in a talk in Rome in the 1890s titled "Do No Harm," essentially said, "The hands take too frequently the place of brains, and such rash feats of indiscriminate surgery are stains on your hands and sins on your souls." And he effectively, with this speech, marked the end of treatment for this condition for nearly 3 decades. And subsequently, there was an evolution of this surgery. A resurgence of interest occurred in the 1930s. By the 1940s, strip craniectomies and suturectomies were once again accepted, but they were advocated early, at the period of 2 months, and there are surgeons who felt that this led to a better functional and cosmetic outcome. But despite advancement in surgeries during this time, a new challenge, ended up occurring in terms of management of these children, because their sutures would reossify, and there would be bridging of the artificial suture as a complication, and subsequent extensive cranial vault remodeling procedures with limited efficacy were then performed. And so that's also important to note, because during this time, we were still trying to figure out what the best technique for treatment is, and sort of the subsequent implications that can happen afterwards. So moving forward, Ingraham and Matson at Children's Hospital Boston around this time popularized the suturectomy. And again, there were advances during the time with anesthesia, blood transfusion, and surgical techniques. And in their series of 394 patients, only 2 deaths occurred. And that really pushed the field even further in terms of the safety of surgery. In the mid-1960s, Paul Tessier, who you may have heard of as craniofacial surgeon from France, he provided the critical momentum and began to change the concepts of surgical approaches, really because neurosurgeons or surgeons who were dealing with brain disorders proved that these surgeries could be done in a safe manner. And so craniofacial surgeons became involved with the focus of the cosmesis portion of surgery and the correction of associated facial anomalies that can occur. So that led way to the early 1960s and the mid 1990s, where extensive cranial remodeling procedures were employed. And that's really because there were limitations of simple suturectomies for advanced late disease. And I do want to bring up, I would be remiss if I didn't, that a lot of the research and theories involved with the craniosynostosis came really from where I work today at the University of Virginia, from John Jane Sr. And one of his residents, Delashaw, wrote this article. Delashaw, you may heard of, is a skull-based surgeon now, but he redefined the mechanism of the pathology, essentially, corroborating Virchow's law in terms of the fused sutures, but also adding that the reduced growth along the margins of that plate, which really act as a single bone plate, result in compensatory, and that's key, the compensatory skull growth that occurs symmetrically along sutures. And so you can see here on the right an illustration from their article from 1989. We see that according to Virchow's law, if the unicoronal suture is closed, you would get some flattening of that ipsilateral side. But in fact, there are compensatory changes that occur from the other sutures that are open. And the reason this is the brain is rapidly growing too at this time. And so the brain needs room, and hence the skull grows a certain way. And we'll talk a little bit about each suture and what these compensatory mechanisms and growth patterns are later in the talk. So the need for immediate deformity correction to prevent neurological dysfunction and treat secondary changes at sites away from diseased sutures really also was a pivotal role in terms of extensive cranial remodeling. And so there are different approaches in terms of surgeries, which we'll talk about, but the term cranial vault remodeling, can encompass a lot of different techniques, including wide strip craniectomies and bilateral parietal osteotomies, vertex craniotomies, midline craniotomies with occiput resection, the so-called PI procedure and the modified PI procedure, the frontal orbital advancement, and we'll talk about each of these in their respective categories. But really, in the 1970s, the fields of neurosurgery and plastic surgery kind of merged in terms of treatment, and we now know this and are familiarized with the craniofacial surgical team with really goals of opening cranial morphology and function. It's also important to note about the modern endoscopic strip craniectomy, where a lot of centers are treating this. Early in the 1990s, Jimenez, who is a neurosurgeon in Texas, and Barone, his counterpart plastic surgeon, they recognized the limitations of the approaches and proposed a novel technique, really building on works from what we discussed earlier, but a simple suturectomy followed by cranial helmet molding. And these really were based from three principles. Earlier surgeons who advocated earlier surgery in life for this condition, Moss's functional matrix theory, which really defines how rapidly growing brain would cause an expansion of skull into a normal shape, and then helmet remodeling, which was introduced by Pershing, who was a plastic surgeon here at University of Virginia, incidentally, in the past. And that tends to counteract the tendency of the cranial vault to revert back to its prior shape. And so this is his article from 1988, sort of talking about his first 4 cases and the ages from 2 weeks to 12 weeks, the blood loss, which was considerable at that time, and now with refiner techniques, you know, is very reasonable and less than a cranial vault remodeling surgeries. And so this really started the next generation of treatment options. So I think Dr. Saman and Ahmad asked me to sort of ask questions to keep people engaged. So I just wanted to open up for maybe a speaker or a participant to talk about, you know, what are really the reasons or indications to do this surgery? Why do we even bother to do surgery? Does someone want to chime in and maybe say a few things?
There is somebody, Mia Iftikharul Haq. Can we switch on his mic, please?
Yes, sir.
Yes, Iftikhar, carry on. Hello? If Iftikhar can't talk, then can you switch on Adnan Khalid there, please?
Hello.
Yes.
Hello. Thank you, Dr. Hasan, for a detailed topic and presentation. Basically, there are 2 indications of surgery in craniosynostosis. The first indication is that of cosmesis, and the second was it because the growing brain needs a space for the development. So that's why we need to provide some space for the brain. So these are the 2 main indications. What is the cosmesis, which has a psychological impact on the family as well as on the parents. So these are the 2 indications.
Thank you for participating, and you know, absolutely, I totally agree with you, and you summarized it very well. There's a wide variation of the management of these types of disorders depending on the center, and treatment really is based on age of presentation, the location and number of the synostosis, the severity of deformity, and the preference really of the craniofacial team, and what techniques, you know, that they're familiar with and they're comfortable with, and the types of equipment that they have. But absolutely, in reiterating what you were saying, there are 2 real main indications, and that is 1, to correct the skull shape for aesthetic and psychosocial considerations, and 2, to provide adequate space for brain growth. And so I want to touch upon sort of the comparisons between endoscopic approach and the cranial vault remodeling. Again, a general term, but we'll go through what that means. So endoscopic suturectomy is best performed, you know, within the first 1 to 3 months. Earlier studies, you know, went all the way up to 6 months. You know, in my opinion, I think, you know, 3 to 4 months is probably the max in order to get the best result. And during surgery, the abnormal bone is removed, and then helmets are subsequently used. The pros of this procedure really are, you know, very small, 1 to 3 2-centimeter incisions. Certainly there's literature now that supports less blood loss and shorter hospital stay. The cons are using a helmet, and the helmet can be costly depending on who's manufacturing it. It does require frequent visits for reshaping it, and it's used for, you know, anywhere from 9 to 12 months, you know, up to 23 hours per day. And of course, you know, just like any surgery, there aren't, it's not 100% in terms of If its efficacy, certainly sutures may refuse, and that can happen in open procedures as well. Cranial vault remodelings usually are done 4 to 6 months of age for sagittal synostosis, 9 months of age for frontal-orbital advancements for, such as metopic synostosis or unicoronal synostosis. During surgery, the abnormal bone's removed and the head is reshaped, and we'll go through that. The pros are the surgery really fixes the head shape right then and there. There's no need for a helmet, and there's, in that sense, parents don't have that anxiety of the helmet. The cons are it's a larger incision, usually more blood loss that requires transfusion and a longer hospital stay. A little bit about cranial molding helmeting. The way that we do it here is that we have baseline measurements prior to the operating room so that it can be begin the manufacturing process. A 3D scan 1 week post-op, followed by the helmet starting about 2 weeks post-op. Usually, in most cases, this doesn't really affect the incision. Kids are very good in terms of healing, and it's worn, as I mentioned, for 9 to 12 months. Must be worn for 23 hours per day and adjusted usually every 2 to 3 weeks. Sometimes, at least, again, where I practice, families, come from farther away and just don't want to come for reshaping every 2 to 3 weeks, and that can be a limiting factor in terms of the technique they use. So that's something to keep in mind when counseling patients. So let's talk about the epidemiology of synostosis. So this really occurs 1 in every 2,000 to 2,500 live births. The pathology can be single suture or multi-suture related. Multi-suture related are sometimes associated with genetic mutations and syndromes. As we briefly talked about before, sagittal synostosis is the most common, occurs 60% of the time, followed by coronal, then metopic, and lambdoid is exceedingly rare, but can be seen. Important to note the normal closure times for these sutures as well. Metopic usually is 3 to 9 months, and so you can commonly see patients in clinic, or at least we do, where there's some concern. Metopic ridging is also another phenomenon that where there is the phenotypic ridge. However, there aren't any other signs like hypotelorism or developmental delay. And metopic ridging is usually something that does not require surgery and can just be followed. And if there are concerns about the ridge from a cosmetic perspective, it could be burred down at some point in the future. That's also something to keep in mind. Sagittal sutures usually close by 22 years, coronal sutures 24 years, and lambdoid 26 years. So they're, when a CT scan is done, even in teenage years, those remain open. The etiology is multifactorial. Briefly, it's incompletely understood. There can be sporadic mutations. There are metabolic and hematologic syndromes associated with this condition. Certainly teratogens in the gestational period. Maternal smoking and advanced paternal age have also been associated with causes. There are a whole host of genes as well. And so oftentimes parents do ask, is it something that they did, or could have this been prevented? And again, what I try to do is kind of reassure the parents who are already nervous that there isn't anything that they did to cause this. And I think that's also a role that we play in terms of counseling our parents and our families as well. So I do want to mention craniofacial syndromes. I think this is important, especially for trainees, because you can see this in your board exams as well. Some of the more common craniosynostosis syndromes are Apert's, Crouzant's, Seth-Shotson syndrome, and Pfeiffer syndrome, and we'll briefly go through both of them with some examples. So Apert syndrome was first described in the early 1900s, and as you can see in the pictures, the skull shape is really tall and shortened, also known as Turry brachiocephaly, and there's some mid-face, you can see maxillary protrusion as well. Proptosis and hypertelorism as well. This condition is also associated with learning disabilities, and you can see syndactyly is present as well. Crouzon syndrome, described in, I believe in the 1910 or so, and typical features include a retruded maxilla, a beaked nose, a recessed frontal region, and brachiocephaly, as you can see from this photo. You can also see there's exorbitism or a recession of the infra and supraorbital regions as well. And this also complicates treatment options as well. Crouzon syndrome is one of the syndromes where syndactyly is absent, and something that could be tested as well. Schatzen syndrome, described in the 1930s. This can have variable features. Patients can have short digits, partial syndactyly, a low frontal hairline, as you can see from this picture, a prominent nose, and ptosis as well. Typically, the synostosis seen here is unicoronal or bicoronal. Pfeiffer syndrome has different types. It's subdivided into type 1, type 2, 3 different types. So it's associated with bicoronal synostosis or pan synostosis as well. You can see there's some digital abnormalities here in the foot. You can see a hallux deformity. Type 1, which is more commonly seen with bicoronal synostosis, is seen on the left picture here, and on the right, type 2 and 3, they have more a severe degree of midface and facial retrusion. Also something that is important to know and can be tested. So just some genetic mutations for craniofacial syndromes. Mostly, FGFR 1, 2, and 3. Twist gene is mutated in the Schatzen syndrome. Carpenter syndrome we didn't really talk about, but another genetic mutation is the RAB23. So timing of surgery. I know this is a question that some of you may have. Does anyone want to sort of speak to that? And I'm also curious to hear about what's done in Pakistan.
Any takers? If you have any, if there are any takers, raise your hands if you want to answer this. When do you think we should be operating on these craniosynostosis, or when would you think we should be treating them? Okay, we have Almedi. Can we, yeah, Almedi, you are on. Go on, please.
Thank you very much for this important presentation. I'm Dr. Habko Elmedi from Morocco, Rabat. Usually in our center, we treat this kind of pathology in the 6 to 9 months.
So thank you. Thank you for that. Yeah, that is, I agree with you as well. And let's talk in detail about that and some philosophies behind the timing of treatment based on the synostosis as well. So sort of the philosophy, let's talk about a different philosophy. So a lot of people will believe that limited operations are successful in younger infants. So we're talking weeks to months, and that's really the premise behind the endoscopic treatment option. Some people feel like delaying until the 9 to 12 months range for certain pathology is better because the skull is hardened, and that minimizes revisions. You sort of treat the secondary or compensatory effects of the skull as well, and that takes care of the condition altogether. There have been studies, important to note, that document that that there is some change in the endocranial base if a child is operated on before 6 months of age that isn't seen after 6 months of age, but the literature on that is sparse. But that's also something that treatment early can have more of a global impact as well. So possible other things to consider is there can be sort of negative effects of synostosis on developing brain. Low grade elevations of ICPs have been seen and described in the literature, but the significance really is unclear. PET scans have shown that there's improved brain metabolism after release. Infants who fail to demonstrate consistent neuropsychological defects, and the neuropsychological implications of this disorder is also difficult to quantify, but there are studies now looking into that as well as it relates to timing of surgery. Older children have shown cognitive and behavioral impairment with sagittal and metopic synostosis. And so that really kind of argues for early treatment. But again, these studies are limited by the fact that it's hard to compare with patients, a patient population who hasn't had any treatment whatsoever. In most cases, treatment occurs, and then you figure out whether this developmental delay or neuropsychological effects are due to the timing of surgery, are they due to the kind of surgery, or is it that this was just going to occur no matter what? So that's why it's difficult to say for certain. But in general, these are general just considerations. 3 to 9 months is largely considered the optimal time for surgery. So, you can do remodeling during this time if you want to do the endoscopic approach. We know, not clear the physiology behind it, but when we take bone off and there are defects within the cranium, when surgery is done at this age, reossification occurs, and we think this reossification, the signals and pathway come from the dura. Again, there's research ongoing in terms of the pathways behind that. During this age, it's important to note that the bone is also more bendable, and that surgery can be easier in a way. And if you are able to sort of attack the pathology early, you can minimize facial dysmorphisms that can occur in multi-suture craniosynostosis or other conditions. Some advocate for greater than 12 months as well, but the calvareal bone is less easily molded. There's unpredicted reossification. As we talked about, the skull base does not change, and the facial dysmorphisms persist or progress longer. So, this is a slide that I sort of use to sort of put everything together. So, and I'll share what we do here at the University of Virginia. So if we see a child that's less than 4 months and the parents are willing to undergo helmet therapy, we will pursue endoscopic techniques and then use postoperative helmeting to direct skull growth. 6 to 8 month range, have used springs or posterior distraction for bicoronal synostosis or multi-suture synostosis, like Lambdoid synostosis. It can be used during this age, and again, the reason is to provide growth for the brain, and I'll talk a little bit more about that too. Otherwise, if parents are wanting to do the cranial vault remodeling surgeries, the open procedures, we typically do that between 6 and 12 months. For sagittal synostosis, we will do it as early as 4 to 5 months as well, again, if they don't want to do the endoscopic approach. So what about older children? This is something that comes up as well. When you look at the literature, it's not, there's a lot of different opinions, but certainly I want to kind of pass on what I think is important and maybe discuss this later on. But, what do you do with a child that comes in, when they're 5 or 10 and they do have, phenotypically, they have signs of craniosynostosis and they're having symptoms, or a child who does have a phenotypic characteristic head shape, but doesn't have symptoms, and you're seeing them in clinic. And I have seen a certain patients like these in my clinic, but also in my training. And I'll tell you sort of the algorithm that we do. So first of all, why are they seeing a neurosurgeon? If they're having clinical symptoms that that make you suspicious that there's elevated intracranial pressures, that's important. So you must ask about headaches. When are the headaches? If it's associated with lethargy, and children, if there's developmental delays or regression of developmental delays. Also important to do a clinical exam and find out if there's signs of elevated intracranial pressure. And this includes a formal ophthalmological evaluation to check for papilledema as well. And in those cases where it's sort of uncertain, you can do intracranial pressure monitoring or a bolt. And we do that in the operating room and then observe a child in the hospital for a couple days with provocative testing and see if there are, in fact, increased ICPs. And if there are, then, it may be that this child does need a cranial vault expansion. But in the absence of that, if there's no objective data, then, it may be better to continue watch it. And sort of that's where the pathway of working these older children up is. So how do you counsel parents on surgery? This is important for trainees when you talk to patients and parents in clinic. So really the risks of these surgeries include bleeding, especially important when taking bone off near the sinus, and particularly the transverse sinus. There can be significant bleeding, and so that's important to discuss with parents. Typically, because the suture is fused, it is easier to lift the bone off, and so that risk should be low. Obviously, risk of infection, CSF leak, durotomy, and the need for reoperation. Preoperative considerations are important too, including an arterial line. We used to use central lines before I joined, and now based on how we're doing these surgeries, we typically do not place a central line. We do have precordial Dopplers and inform anesthesia about the possibility of venous air embolism, and that's important to note. Certainly the techniques to help prevent that when it does happen in the operating room includes dropping the head of the bed, irrigating the field, coagulating any bleeders. Of course, having blood in the operating room or nearby in case there is significant blood loss. What are the complications? So in the acute phase, blood loss is important to keep mind of and doing lab work in the post-op period. CSF leak as well, and if it's noted, a durotomy is noted, then you should immediately repair that in the operating room. Late complications include abnormal bone healing. This really can be seen when doing surgeries at an older age. And the general rule is if a defect is greater than 2 centimeters, then that should be filled in with a split calvario graft. But of course, you have this discussion with the parents to see if it's something that they do want. Infection, postoperative infection may lead to resorption as well. So there have been reports of transcranial plate migration, and that's why it's important to use resorbable plates. And the mortality, at least in the 1970s, was quoted as 1 to 2%. So let's now move forward to the specific cranial sutures and treatment strategies for that. And so again, these can be board style questions that you might be examined on. Sagittal synostosis is most common, as we talked about. It occurs 3 to 1, more commonly in men, in male infants. You get the characteristic scaphocephaly, which is a boat-shaped head, very long, as you can see in the picture on the right. So the fusion, again, impairs expansion of the width, and then there's compensation by growing an increased length. There can be associated dysmorphisms, including bossing of the frontal bone, as you can see on the picture on the right. You can have a bulging of the temporal bones. You often see occipital bulleting as well. There can be telecanthus or increased distance intraorbitally, and you get expansion of the anterior and posterior fossa, again, because the brain does need space. So these are pictures, again, from publications from Jane Senior from our institution of the PI procedure. And so this is basically taking care of the compensatory growth and releasing the skull in order to provide more space for the brain. And so the bone that's left is sort of in the shape of the Greek letter pi. And so you can see pictures of that. The surgery was done here at UVA. And this is, again, another picture of that as well. And so you can see This is why the procedure is known as the Paed procedure. But beginning in 2007, the surgeons here at least were operating based on how the compensatory, what the compensatory changes of the skull were. And so the three types of pathology they saw really were compensations that occurred equally, more anterior compensation or more posterior compensation. And the surgeons here previously would do surgery based on what they saw. And so this really was known as sort of an H-type craniectomy. And so in all these operations, the coronal, sagittal, and lambdoid sutures were removed, as you can see here on the picture of the right. And so then the bone was used to place sagittal strut grafts to increase the AP width of the skull and fixate the skull completely by doing an AP squeeze with plates. And so you can see here, this is sort of equal compensation without frontal bossing, and so you get a nice round appearance. But what do you do when the sagittal closure is mostly anterior? Again, this is a question they asked. And so at that time, what they did for this type of patient was a bifrontal craniotomy as well. And they would flare the frontal bones and again, try to get the flattening appearance or round appearance of the forehead. And so in terms of what do you do if the posterior sagittal suture is more closed? Again, they would design the craniectomy to include the occipital bone and do a posterior osteotomy to release the knob. Again, another picture here showing that, flaring that in order to flatten the skull. And so that sort of philosophy gradually changed to this procedure. And this is the procedure that I started doing when I joined the University of Virginia, because I found that this had good results in my training. And so this is known as the flag procedure. And I'll explain what that is. It's called the foreshortening and lateral expansion of the cranium activated by gravity procedure. So essentially what we do is we take 4 to 6 centimeters of the parietal bone encompassing the sagittal suture. We then do parietal cuts or barrel stave osteotomies to increase the AP width of the skull. And then we take care of the occipital bulleting as well by making cuts in the occiput and flaring it out. And where the lower part of exposure, where the occipital bone is, we will do we'll drill the bone down up to the inner cortex, and that essentially creates a hinge. And so post-operatively for 2 weeks, we instruct the parents to lay the child flat on a donut pillow, and the results have been very good in terms of a normal skull shape. And so this is an example of that procedure, a 5-month-old, where the parents noted scapulocephaly. So we see a bicoronal incision, a CT scan for diagnosis that confirms the sagittal synostosis. This is, again, after taking 4 centimeters out of the craniectomy and then flaring out the parietal bones. And so you can see that there's a wide area of dura exposed, essentially a huge soft spot is what we tell parents. But at this age, as we talked about, the bone does reform. And so you can see here, this is a post-op scan 6 months after surgery, and you can see the nice round appearance of this patient. There's some skull that is bone that's missing, but that will continue to fill in over time. So the results have been very good. Now, again, this is the method that I prefer. This is a 3-month-old boy with scapulocephaly. Again, the parents were open to endoscopic craniectomy and helmet therapy. And so this is his post-op scan a few months later showing some filling of the bone, but rounding out of the skull shape as well. So there's the technique really involves either 1 or 2 incisions. an endoscope for dissection of the galea off the bone, followed by a burr hole at the center of the suture, stripping off the suture from the dura, which is usually very easy because of the fusion of the suture, and then using Tessier scissors or various instruments to take off, usually about 2 centimeters in width of the sagittal suture. So just an article that was published in 2018 analyzing the treatment of sagittal craniosynostosis, and this is from Boston by Dr. Proctor's group, 207 patients, 187 treated with suturectomy and 20 with the cranial vault remodeling. You can see that the operative time was less hospital stay, and the transfusion rate was 2% versus 85%. The cranial index Z-scores were initially more favorable for the endoscopic, but then by 3 years they were equal. Important to note, 4 syndromic patients were treated by endoscopic, but required secondary expansion for raised ICPs. And so their conclusion was that it was an effective treatment for non-syndromic sagittal synostosis. Again, the limitation of this can be for syndromic or multi-suture cranial synostosis, just something important to note when counseling parents as well. In terms of outcome, again, no definitive study, but as we talked about, there can be association with learning disabilities compared to the general population, although there is normal intelligence. But it's hard to know if this is due to the actual pathology itself or something that has been or would have been present no matter what. So moving on towards unicoronal synostosis, this is the second most common, more common in females. This results in progressively mid and lower facial deformity. It's associated with strabismus and astigmatism. You can get frontal deformity of the more so compared to the occiput. You get an ipsilateral frontal recession and occipital protrusion, and contralateral frontal bossing. You can see a picture here of that. Ipsilateral frontal flattening, contralateral compensatory bossing, and then the so-called harlequin deformity as well. So this is a child, a 10-month-old girl who actually saw in clinic earlier this week that we're scheduling for surgery. Again, a CT scan was done to confirm the suture that was fused, and you can see here that the harlequin deformity we talked about. More challenging to tell from a top-down view. Certainly you can see that on the CT scan as well. So the surgical technique, the traditional technique, really is the bifrontal craniotomy and frontal orbital advancement. There are some groups who will just do a unilateral frontal advancement, orbital advancement versus bilateral. But really surgical pearls for this are, a craniotomy 1 centimeter above the orbital rim and the midcranium. You want to avoid the cranial suture because if you include the cranial suture in the remodeling, that can lead to hollowing. Important to dissect the orbit properly and do the various osteotomy cuts that can be seen here on the right to take off the orbital bandeau and then recontour it. Typically, the segment that is synostosed, we purposely increase or advance that part of the orbital rim, several millimeters more than the unaffected side, because after surgery, as the healing process occurs, it naturally will try to fall back to the position that was in before. And so we found that by overcorrecting, really, that has the best cosmetic results as well. And these are some intraoperative pictures of that, of the exposure, the orbital bandeau and reshaping it, and some postoperative pictures. You can see your left pre-op and right post-op, how there's nice rounding of the forehead.
Hasan, I'm sorry, there are a couple of questions. So I was wondering if you could take those questions in the middle.
Yeah.
So we're going to, there are 2 people who are raising their hands. One is Iman Eucliffe. So you're on. What is your question? Hello, Imani. Okay, so let's mute the gentleman back or lady back, and then we go on to the next person who's raising their hand. Yes, have you got any questions? Who's this and where are you from? Okay, both of them have raised their hands and are not there. I'm sorry to disturb you in the
No,
middle
you're
of it.
fine. No, I'll try to speed this up too, because I know we're at 50 minutes.
No, we are fine. We have time. Don't worry.
Okay, that's fine. This is another interesting case that I had a 6-month-old girl with right unicoronal and metopic synostosis. So you can see sort of the characteristic head shape that we discussed. And intraoperative, you can see the metopic ridge and the unicoronal synostosis. And so this was sort of challenging to correct because the forehead is already affected. And so in this case, I wanted to show some intraoperative pictures, similar cranial wall remodeling. A lot of times when you see patients, even though you have a plan in your head, when you're seeing them in the OR, you have to come up with a plan. And so it's also important to think on your feet. But this is after the bifrontal craniotomy. Obviously because of the metopic ridge, what we ended up doing was designing the forehead based on the posterior cut. So essentially what we did was we turned the bone around, and this portion became the forehead because it was nice and round. And so you can see that in this picture, the final picture, the craniotomy we did to introduce a new forehead and placing bones back and making cuts in order to have a normal head shape. This is a 3-month-old who had a right unicoronal synostosis. This was treated by an endoscopic approach. And so Jimenez and Barone, we talked about, described the first 100 patients in this 2012 article. And they mentioned that there was significant correction of vertical dystopia and mid-sagittal plane deviation. And so this became also a very good technique. Usually it requires 1. I've done 2 incisions as well. Sometimes it's difficult to get lower down to get the entire suture. And so I've used 2 incisions. And this is post-operative pictures. In this case, it was 1 incision. Again, pre-op, nasal deviation, Harlequin sign, and you can see that has significantly gotten better in terms of the head shape. I think it's also interesting to talk about bilateral coronal synostosis. It's more commonly syndromic. There are more females than males. These patients present with brachiocephaly, or a short head, a flat occiput, and can show pterocephaly, which is a towered head. And so this is an illustration of that. You can also get facial deformity, which includes a high forehead, superior orbitism, and then hypertelorism as well. And this is a child who, I was consulted on by our a neonatal intensive care unit. This is a 1-month girl who was born prematurely, but you can see probably some abnormal head shape, has bicoronal synostosis, and you can see sort of the development of the pterocephaly. And so this is a child who would be a good case for an endoscopic approach that we're planning to do next month. Again, the surgical techniques for bicoronal synostosis is a little more involved. There are three different approaches, and again, it depends on each center. Some people will go for a frontal orbital advancement up front. Some will do an early posterior release with distractors, and the reason being is it avoids the development of secondary pterobrachiocephaly and other mid-face issues, and it allows the brain to grow. And then in the future, that's followed by a frontal orbital advancement. And then others will advocate for endoscopic suturectomy followed by helmet therapy. So this is an example here from UVA where a 6-month-old girl was found to have bicoronal synostosis, and you can see the pre-op CT shows that. And so what we decided to do was a posterior distraction technique to allow the brain to grow and to prevent secondary effects of or the compensatory effects of the primary fusion. And so these are distractors that over time parents turn, and that creates the space that the brain needs. And so this was followed at 14 months of age with a frontal orbital advancement. And so you can see pre-op images to the left and then post-op images afterwards. And so we got a nice correction of the forehead, and hopefully this will allow the child to grow, brain grow, and cosmetically do well. So this is a 3-month-old girl.
Sorry, Hasan, there is a question.
Sure.
What plates do you use?
So we use, there's 2 companies, Stryker and KLS. These are absorbable plates. So we use absorbable plates, and they tend to stay around anywhere from 6 months to 12 months. They slowly resorb. Sometimes parents do complain, or you notice in post-op visits of protrusions because of the plates, but they do resorb over time.
And are they rigid? Are they rigid, or they are soft ones?
So they are rigid, but in warm water you can mold them to whatever shape you need, and then they stay rigid. So this girl is a girl I treated with bicoronal synostosis using the endoscopic technique. When you look at these images, just to point out, this is, again, we're always learning, even attendings, consultants, by cases we see. In retrospect, you can see that this child has bicoronal synostosis. She's already distracting herself. You can see the lambdoid sutures are splayed. And while initially I saw this patient, I said, I'm going to try to do this with the endoscopic approach. I think when you see this also bodes well for an endoscopic approach, because again, the compensatory effects of the primary problem is mitigated. And so this is immediate post-op images. You can see a nice suturectomy we done, 1 to 2 centimeters, followed by helmet therapy. And you can see at 12 months of age, the bone starting to fill in, but the sutures are still open. So you can see the nice result. Just look at the orbits and how they were pre-op. You can see sort of the harlequin signs that we saw in post-op. Definitely a significant improvement. So endoscopic outcomes, very briefly, again, for bicoronal cranial synostosis, 18 patients, 11% of non-syndromic patients required subsequent FOA. Again, important to note, more common in bicoronal needing subsequent surgeries versus sagittal. 55% of the syndromic patients underwent subsequent FOA as well. So that's important to note if you're considering this treatment option, and also for counseling purposes as well. This is an article in terms of outcomes that came out of Boston when I went to see Dr. Proctor and did some time with my fellowship, that traveling fellowship with him. Again, all these craniometric measurements that we measured, including anterior cranial height, base length, frontal bossing, cephalic index, they improved, and certainly shows that the endoscopic means it is possible for these select cases. Outcomes, syndromic versus non-syndromic. You can see syndromic patients all usually do have other issues in terms of the face. So moving on quickly for metopic synostosis, third most common, more common in men.
Sorry, Hasan, there is another
Sure.
question. That there's somebody is saying, Satya is saying that their maxillofacial colleagues do a lot of interesting, detailed, complex calculations to plan correction.
Yes.
Do you use such formulas as well?
So we do, specifically for coronal and for metopic synostosis, intraoperatively we will measure the orbital ridge, the inferior and superior portion of it. And then what we try to do is the difference between the two, because of the hypotelorism, we expand the bandeau, and the strut graph that we use is dependent on those measurements. So I do these surgeries with our craniofacial surgeon, and so their help is critical in these types of surgeries. So metopic synostosis, you get the typical trigonocephaly or triangular shaped head with a mid-frontal keel and bifrontal narrowing, and these patients are considered most at risk for cognitive or behavioral impairment as well. We talked about the facial deformity. You can see here on the picture of the right, the temporal narrowing, the recessed orbital rims, the hypotelorism, all important. There can be compensatory changes, including the parietal flaring that occurs in order to get brain more space. So the surgical technique is sort of similar to the frontal orbital advancement techniques we talked about. This is a patient of mine that required surgery. So what we want to do, and these are intraoperative pictures, is a bifrontal craniotomy with recontouring in the frontal orbital advancement. We want to achieve symmetry of the forehead. And so here's a picture where we're doing the dissection of the orbital bandeau, and we're using the sonopet serrated tip in order to safely take the bandeau out and the various cuts that are required. This is the bandeau, and you can see the metopic ridge there and the triangle shape of the bandeau. So as I was talking about, we reshape the head by flipping the skull around. So this was the front of the forehead, and this was the back. But when we flip it around, this has a nice round shape, and so we use that and bone here to do an interposition graft connecting the bandeau to correct a hypotelorism as well. So you can see here we're shaving down and inserting the graft, and this is sort of the end result of that correction with the absorbable plates. And this is the immediate post-op picture that shows sort of nice rounded shape that will round out more in time.
There's a question, how do you sort out the supraorbital nerve?
So great question. So usually, obviously, there's that foramen. And so sometimes there's a ridge between the orbit and the foramen, so you can dissect the supraorbital nerve already. If there isn't, then you can use kerosene punches to create an opening, and then using various dissectors, it's usually very simple to dissect the supraorbital nerve. There are times where you can't, or by accident the nerve is avulsed, and in most cases in kids they tolerate it well. So moving on towards the endoscopic technique, again, it can be done. There's good results. In terms of surgery, it requires an incision right behind the hairline. Again, a 1.5 to 2.5 centimeter suturectomy. Oftentimes, I've noticed there's usually some emissary veins, and so it's important to, when that's exposed, to coagulate that to decrease blood loss. And then you can also use an ultrasonic bone aspirator to reach the nasofrontal suture or junction. It's important to get to that point to fully to release that and have the helmet work optimally. In these groups, there's a high incidence of cognitive and behavioral impairment, but again, there's unclear etiology and significance, and it is possible that it just could be a primary problem rather than a secondary problem. Lambdoid synostosis, finally, is the least common and more commonly occurs in men. Important to differentiate between plagiocephaly versus lambdoid synostosis. So plagiocephaly, you can see a trapezoid, a parallelogram shape because of anterior displacement of the ear, ipsilateral displacement of the frontal bone, and flattening of the ipsilateral side with contralateral bossing of the occipital side. In lambdoid synostosis, it's more of a trapezoid skull with posterior and inferior displacement of the ear and the mastoid. Surgical techniques vary as well. There's open techniques where you do bilateral occipital craniotomies and osteotomies in order to flatten that area out. This is a 9-month-old with bilateral lambdoid synostosis, and so you can see here we did our craniotomies and reshaped the back of the skull. Again, when doing this, it's important to be mindful of the sagittal, of the transverse sinus. This is an 8-month-old girl with lambdoid, right-sided lambdoid synostosis. Again, an open procedure in order to correct it. So endoscopic techniques have been used as well, just to point out lower numbers, 4 in this series of 173 patients. Subjectively, the authors felt that there were excellent reduction of that windswept appearance that you can see in the coronal plane in lambdoid synostosis. And then the pre-op head circumference and cranial asymmetry improved as well. So now just to briefly talk about how we changed, or evolved our practice. I talked a lot about this already, but we went from the PI type of procedure to the H type to endoscopic, and then also the flag procedure. So we just wanted to compare our patients between 2008 and 2018 and see what their outcomes were in terms of surgical time, length of stay, transfusion volume, cranial index, and complications. And so we talked about the H type that was done, and then the flag procedure. And so these were the results. There were 94 patients in this time period. This was really interesting for me to see because this is pretty much like 6 months, less than that, when I started, and I just wanted to see what the comparison was, since there's so much history of craniosynostosis here. And so we saw that there were 64 H-type procedures, 9 flag, 5 endoscopic, and other including distraction, so a total of 94 procedures. These were the mean ages, of course. Endoscopic 3.4 months versus the flag 5.4 months versus the other ones which were done at a later age. Intraoperatively, procedure time compared to the H type, which took 4 hours, we're able to do this flag procedure usually in about 2 hours or less. And then the EBL, you can see is about 300 cc's, which is significantly less compared to the H type. Endoscopic is even less than that. The transfusion rate is high except for endoscopic. In our center, the anesthesiologists usually end up transfusing sometimes even before we start the case in anticipation. And so that's something that we're continuing discussions with them. Post-operatively, the flag type of procedure did not require many transfusions, and that was significant. The length of hospital stay for our version of the open procedure was 1.3 days compared to 1.7 days. And the length of stay was also significantly less. In terms of the results, there is no significant difference. So all of them achieve the goals that we want to achieve. And so the conclusions were that all procedures had similar results. There's decreased surgical time, transfusion volume, and hospital stay for flag and the endoscopic groups. Of course, we need our long-term follow-up for this, and we're looking forward to continuing to follow our patients. And that's also another point to make, that you don't just do the surgery and then not see them, these patients. You want to continue to follow them to see how they do and to really assess their neurodevelopmental milestones as well. So I'll end with this, just something for the trainees when you go out to practice. If you're interested in sort of focusing this, how to build a craniosynostosis center, really it's important for referral patterns. You really have to talk to community pediatricians and do educational talks, discuss the timing of surgery and the need for surgery. You have to encourage referral as soon as possible if there's a suspicion for abnormal head shape. The early diagnosis is critical. Even if you don't necessarily treat endoscopically, it really gives family the time and to come to terms with the diagnosis. It can be very challenging for parents, and emotionally, it has emotional effects as well. And then again, why I find this very, fun as well is, you're establishing a multidisciplinary care, and that involves various teams and, craniofacial surgeons, audiologists, dentists, ophthalmologists. And it's very fun interacting with these groups of people and seeing what they focus on in this patient population. And of course, you learn as you continue to do with experience. And so I just wanted to end on that. Again, I put my email address in the bottom left. If there's any questions or concerns, things that I can help with, I'm happy to do that. I want to thank everyone for their attention. I know this was a longer talk. I hope you guys were able to learn, something new or get another perspective. And again, thank you very much.
Thank you very much, Dr. Hasan. Can you hear me?
I can hear you, sir. Yes, thank you.
Thank you very much. It's an talk. I'm sure most of us have learned a lot of things. And there's a few questions that are asked by the participant. One of the participants asked, do you remove the pericranium along with when you're doing the suturectomy?
That's a great question. So typically what I've been taught and what I do is that when we're doing the exposure, we don't remove the pericranium. One of the main reasons that is once you do, you'll see that that the skull tends to bleed a lot more. And so just for you know, blood loss perspectives, it's better to keep it on in terms of the exposure.
Thank you. Another participant asked how many patients suffer sagittal sinus complications?
That's a good question as well. So, you know, thankfully, we haven't had any here. I think if you quote a percentage, it's going to be low in the single digits. Typically, what can be seen is venous air embolism, and that's why it's important to have anesthesia aware of that and precordial Dopplers. You know, the typical murmur that you guys are familiar with, the Millwall murmur, you know, can be heard. And if you look at the literature just based on that, you know, non-symptomatic venous air embolism, you know, there's some studies that quote a large amount, you know, even up to 20%. But sinus injury itself is typically rare.
Thank you. So Salman, you have any questions to ask?
Yeah, I'm sure there are lots of questions there. One question is the skin incision. Is it a zigzag incision or do you just give a straight incision?
So again, excellent question. I think both are appropriate. During my training, there were certain attendings and consultants that would use a zigzag, and they had their reasons. I've used mostly a curved incision, curved bicoronal, a waved incision, because it hides well within the hair.
Okay. There's another question by Adil Musavi, who's asking, do you routinely evaluate the cranial volume pre and post-op?
So a great question. So we haven't, or I haven't done that here, but that is something that I would like to do, and something that I think is important as a preoperative and postoperative measure. We typically will get cranial index, you know, measurements and track those.
Okay. What about you know, patients who are delayed and they come late and you've measured pressure and the pressure is high? So what's your take on that? What do you do with that high pressure at that time?
Yeah. So if the child has symptoms and you know, objective data that suggests elevated ICPs, then yes, you know, the cranial vault expansion is the treatment of choice. Now that can be difficult and it can be associated with complications. And, you know, there's various opinions on how to do it, you know, when to do it, why to do it. But I think most people would agree that that is an indication for surgery.
Amir, are you going to ask a question or two, please?
Yeah, there's a question. Do you, sorry, it's not working. My gadgets are not working properly. Do you look for the cause of craniosynostosis in a child?
I'm sorry?
Or it is, you look for the cause of craniosynostosis in a child?
That's a good question too. So if there are multi-suture involvement or, you know, facial features that suggest genetic syndrome, we do get genetics involved. Our threshold of getting genetics involved is fairly low. And you know, again, it depends on your center too, how involved they are, how involved they want to be. But we do that.
Okay, do you use,
when we do the endoscopic surgery between the age of 1 and 3 months, why we wait for 6 months for the open vault surgeries?
Yeah, so that's also a good question. So, you know, it's sort of what we were talking about earlier on. You know, people were doing surgeries at different stages, you know, in terms of the evolution of surgery, and they were doing it 4 months, 5 months. And so, in these surgeries, the refusion rates, reossification rates were seen, and then they would have to do additional surgery later on, and that would be more complicated. So the general trend or understanding or philosophy is that if you wait a little longer, these secondary and compensatory mechanisms that occur in the skull can be corrected, and that will be the one definitive treatment.
Okay, Ahmed Anwar, who wants to ask a question, we're going to unmute Ahmed. Would you like to ask the question directly?
Yeah. Can you hear me?
Yes, we can.
Salman, nice to see you after a long time. Hasan, very nice presentation. My practice is also pediatrics, and we receive patients who had surgeries other part of the world. I'm practicing UAE. What is your assessment of follow-up with the head circumference, because they don't follow the normal trend? And second, how frequent you get ophthalmology assessment in your redo surgery?
Sure. So I'll answer your second question first. We generally get ophthalmology involved, for every child in terms of follow-up as well. Again, it's important to see if there are signs of papilledema even in the post-operative period when you're following a child years afterwards. So that's an answer to your second question. The first question, in terms of what the head circumference does, if you look at outcomes, the literature in terms of outcomes and the reports of head circumference, after cranial vault remodeling or even endoscopic surgeries, the head circumference usually will increase significantly and almost trends towards what would be normal. I know that every child is different, and so some of the patients that you probably see who've had surgeries and then or have reduced surgeries, they probably I'm assuming are probably a little different depending on the timing of surgery was done or whether there was reossification and things like that. But I think the simple answer to your question is that there is a significant difference in terms of head circumference after correction of surgery.
Okay, brilliant. Thank you.
There is another question. What are the various tools and the methods you use to determine their chronological age and the mental age? Yeah.
So in terms of chronological age, obviously this is sort of what we talked about whenever you evaluate a pediatric patient, you must know their birth history and their gestational age. And so the timing of surgery is based on what their gestational age is. And so, we see patients who were born extremely early and we wait until their gestational age is 3 months or to do endoscopic, or 6 months or 7 months to do the other types of surgeries. In terms of evaluating neurocognitive aspects, I think as a field of pediatric neurosurgery, we can do a lot better. And that's something we've lacked. And even probably in most practices, there isn't an objective battery of tests that are done. But this is something that we can work on as a field together.
Okay, I think we're running out of time. So what we're going to do is we're going to go to the multiple choice questions that our friend has been very kind. He's prepared it for us. So we'll go through this. So there'll be questions and, people can raise their hands and can answer this. So this is basically, Professor Vora, would you want to take it away and read the questions for us, or shall I ask Hasan to read them for us?
Sure.
Which of the following craniofacial syndrome is not associated with syndically?
So Usman
Cruzen syndrome. Cruzen syndrome.
Okay,
that is correct.
Let's move on. Good. Next.
The metopic suture normally closes at what age?
Okay, anybody to raise their hands?
Somebody has answered it.
Hasan?
Yeah, so the Metopic suture closes at 3 to 9 months.
Okay. There's a question above Professor Vora on sagittal craniosynostosis.
Sagittal synostosis is more common in male or female?
Raise your hands, please. Okay, so we have Mohammed Usman again. Yes.
Marcel. Sorry, Marcel.
Sorry, Marcel
Yeah.
is there. Marcel, yes.
Yeah, it's more common in male at a ratio of 3/1.
Okay, good. Let's move on. Next question.
Next. Which of the following are options for managing bicoronal synostosis? A. Endoscopic suturectomy at 3 months. B. Posterior distraction at 6 months of age. Frontoorbital advancement at 12 months. D. All of the above.
So Usman wants to answer this again. Can we switch on Usman's mic, please?
Yes, it's D, all of the above.
Very good. Excellent. So let's move on to the next question. Usman is not allowed to now answer any question anymore.
A 1-day-old child who appears to have premature fusion of multiple cranial sutures, sagittal, bicoronal, and metopic. He has been stable, although with occasional apnea, on examination he has a bulging fontanella. His parents wish to pursue aggressive care. When should he undergo a cranial vault procedure? A, 24 months, B, 6 months, C, 12 months, D, the next several days, E, 18 months.
Please raise your hands. That's Muhammad Naeem.
Yes, sir. It is, sir, B, at 6 months of age.
So I'll just, this was a tricky question, I'll be honest with you. It's one of our board style questions. And the answer is actually in the next several days. And the reason that is mainly because his exam is consistent with elevated intracranial pressures. And so in this case with multiple, and I know we didn't talk about this, but in multiple cranial synostosis, with exam findings of elevated ICPs, it's better to do something early on to release the sutures and to give the child's brain space. And then if subsequent surgeries are needed, to do that at the appropriate time.
Okay, let's move on. That was very good. And look at the answers of people who fill this. So question on syndectomy.
This is the answer?
Yeah, these are the answers. Okay, so majority got it right. Move on, next. Again, majority got it right. Next. Okay, so this is all right as well. Good. And all of the above. Okay. And here, majority felt that into several next few days, so which is fine as well. But you know, quite a big proportion felt that it was 6 months, but I suppose they didn't get it that ICP was raised. So let's get presenters' feedback now. So this is excellent. You've got good and excellent 100%. Quality of content. Keep going. Again, 100% quality of content. Rate of overall presentation, 100%. Would you like to hear him again? Yeah, a couple of people didn't want to hear from you again. But majority said they were very happy. Good.
Thank you very much.
Thank you. So, and Ahmad, do we have the poster for the next talk for day after tomorrow? Ahmad, we are waiting for you. Hello, can you screen share the next talk?
One second.
Day after tomorrow, we have Professor Henry Schroeder, who's the president of the IFNE. He is going to give a talk on ventricular endoscopy. Along with him will be Ramesh Nair from UK, who will be discussing cases. And moderator is from Kenya, Mahmood Qureshi. And we have it, sorry, where did it go again? Oh, this is for, so you've got this. What time is the first one? The Henry's one is at noon o'clock, at 12 o'clock? Okay, so this is noon for Pakistan, and rest it's GMT +2 for Germany. And then the Sunday one. Sunday we have Giovanni Grasso from Palmero from Italy, who's going to talk about hybrid surgery. And as always, Trost is going to show his cases. So we're going to have fun at the same time. This is going to be at 5 in the evening, because just to match things up for people from US to make sure that they're not waking up in the middle of the night giving talk to us. So I'm grateful to both the moderators. I think it was brilliant. I'm grateful to Anjum Saab. You're very, very kind to be here.
Thank you. Very nice meeting you as well.
Oh, it's a pleasure. And all the participants.
Thank you, sir.
And Hasan, as always, was a brilliant talk. So it's we're looking forward to having you again.
Thank you so much. Thank you, guys. And I'm sorry I wasn't able to answer everyone's questions on chat. Feel free to email me. I'm happy to speak to you guys.
All right. Thank you very much. Thanks.
Okay. Thank you, everybody.
Bye-bye.